Hello everybody and welcome to this webinar about the new generation of implants, iBone. So today I had the pleasure actually to be sitting next to Cédric Lancieux, who has been co-participating in the development of this implant, but also Dr. Pinto, who's going to present you different clinical cases on these iBone implants. What you're going to see is this implant actually is the fruit of a long-time partnership with universities, implantologists, engineering. It's not a project that we came up in a few seconds. It's a long-time project. And so we're actually super glad to present it to you today. Just a few rules regarding this webinar. All the questions will be answered only at the end of this webinar on the Q&A box at the bottom. You can see here at the bottom of this of your screen. Another important rule as well: please do not ask sales question or marketing question because they will not be answered. Today we will only focus on the technical and clinical aspects. Last thing, because actually we are just starting a new series of webinar, I will actually invite you to another webinar about digital implantology presented by Dr. Chérus. You can already register on the link that's going to appear on the Q&A box, just clicking, and you will be welcome to participate in this webinar that will take place on March 25th at the same time approximately. So let's start. Dr. Pinto, thank you so much actually for sharing your expertise and sharing this event with us. And if you want to start, you're free to go. Thank you.
It's a pleasure. Hi, everybody. I hope I will find you well. Thank you, Johan, for this kind of introduction. Johan told me that there are 25 countries connected and almost 500 participants. I hope my mother is watching me and English and my French accent. Indeed, the unique situation we all live in, the webinar is part of it. And as you know, in each crisis, the humanity is getting better and the virus has opened a lot of doors. For example, all the technology for this webinar was already for a few years ago, but we were not ready yet. And the similar story is with the new implant concept, the iBone. The majority factors that we will describe further are already new, but there are no implants that have combined them in one concept of surgery, implant, and prosthetic. For the technical aspect, would you like Cédric Lancieux explain us the born of this project, please?
Yes, of course. So thank you. Hello, everybody. So I'm going to give you a short explanation about the story of the development of the implant. So first of all, everybody know about the Brainmark implant. That was a straight implant with a thin thread, and in the 90s. And step after step, need after need, we start to make extraction, implantation, and with this kind of implant, it was really necessary to have big implant in certain case when we straighten molar. So we have some implant of 6 millimeter. We put 6 millimeter of titanium inside the bone. And in the near 2000, arrived some implants like a SPI from iphysio, Nobel Active, Nature Actis. That is very good implant with very good initial stability, but the initial stability is coming from the apex of the implant. So if you make an extraction of molar, the diameter is not enough, so we need again to put a big diameter of implant. And today we would like to keep bone and to put the minimum of titanium in the body of the patient. So in February 2017, it's now 4 years ago, it was a long development with many tests, many try. We start by a small draft about a small drawing about the implant. in order to try to find a solution to reduce the quantity of titanium and to have a good stability on the apex and on the coronal, on the top of the implant. So on the next slide, we have some different drawing, different prototype. So you can see here from 2017 on the left to 2019 on the right. So we start to develop some conical implant, a little bit too conical when we start to make the test. We start the designing, again, some tests. We work with different doctors, Dr. Pinto and others. And step by step, we find something good with a very thin body and large thread for soft bone and thin thread for hard bone, and arrive the iBone. So free design, two shape exactly the same, but with different surface treatment between the iBone E and iBone S, where we have a machine collar, and iBone G when we have a tissue level implant. So the surface treatment is the same for all implants. It's not a new surface treatment. It's a surface treatment that we have already used on all our implants. So it's more than 20 years ago. We have a sandblasting titanium oxide on the implant and clean acid etching. That means that we have no contamination with aluminum, with zircon, or all others. It's oxide titanium on the implant. And 20 years ago of clinical background on it, and very good result about osseointegration. The iBone S as a machine collar is not polished, it's just machine. And this is really done for when you have some patients with some difficulties about the parodont. So if there is any problem, the bone is reducing, and we have 1.2 millimeter of machined collar. So the bone can osseointegration on it, but if there is any problem with the patient, the soft tissue is like this surface, and we have a good sealing of the soft tissue around this collar. So you can see here that it's not polished. Huh? You see the machine thread on the surface. And here we have measures the rugosity, so how is the surface. And we are on the implant, it's 1.4, it's an average, it's a standard surface that we have on the implant. And on the collar is 0.6. So it's between a polish and a rough surface. That means that we have a good osseointegration and a good link with the gingiva. About the range of the implant, we have two bodies, so 3.5 and 4.3. And after that, we have three kinds of thread, thin, medium, and large. So, by example, for the 4.3, we have 4.8 on the thread, 5.5, and 6.2. 6.2. So 6.2 is very good when you make an extraction implantation of molar, because you have stability on the apex of the implant and on the top of the implant. So the stability is very good. Same when you have a soft bone or things like that. 4 lengths for each implant, so 8, 10, 12, and 12 for the 3.5. And when we have the 4.3, that is more for posterior, we have only 4, and we start to 6 millimeter and start to 12. That is enough about when you need this kind of implant in posterior region. About iBone G, iBone G is really a good implant for posterior. You have a very good stability. It's the first implant with high stability and tissue level. All the other implants in tissue level are very straight implants and with thin thread. So here you have a large thread. And this implant is really done for posterior region. So only the 4.3 millimeter about the body of the implant. And after that, we have the 4.8 or 5.5, 6.2 thread. And two platform, we have a RP and WP. That means 4.8 and 6.5 millimeter about the platform. So it's compatible with the Straumann tissue. And it's the same kit. So with the same kit, we have the free implant. About iBone E and iBone S, we have only one connection. And this connection is compatible with our implant that we have today. So we have all the history about our implant. Naturitis, so it's compatible with Naturitis, Natural Plus, and Natlea. So very good background about this connection. One connection, so it's simple about the prosthetic. It's compatible with iphysio, the transfer, healing abutment, scan body, etc. And as I said just before, so it's only one kit, and with this one kit, you can put all the implants. So easy to use. And I will let Dr. Pinto to explain about the kit and about through different clinical case, and of course about the implant.
Please, Cedric, I would like to come back on the iBone S, just to explain that the iBone S will display 3 different states of surface. The first one is smooth and is only the bevel and the internal connection. However, we wished that the states of surface, the part that was hybrid, had a roughness of 0.7 or 0.6, it depends on the machine. So it could be osteo-integrable and at the same time mutio-integrable. So we are going to see the difference between the root surface. So it could fuse with the bony cells. And now we see why. The question is why we decide to do an implant with a microstructure, micro texture for the color. Many studies like this one of Lyra of 2019 and the whole showed that on this kind of micro textured neck, there is the number of the bacteria has been divided by 4, and we have reduced the bleeding on the abutment extract when we remove the abutment. And also the bone level is more stable, and we have a nicer crystallized tissue mucosa. And there's some others study about, like this one, Vandenberg 2018, that show us that there is a better stability of margins tissue on the long term, and some others, many others. I don't want to be too long about that, but there is an interest. This study about Susan. Susan makes this very nice study on the mini pig, and he showed that this surface help a lot to stabilize the marginal tissue on a long-term basis. And when you see this micrography, we see that the bone is going on this surface, though it's really an osteo-integrable surface. It's not something that polished and it cannot, the cells cannot stay on it. Okay, so be careful to understand that. Okay, what is really interesting in the previous presentation is to understand that we thought that about something completely different that from what we were used to. Our first goal is to preserve the bone, to preserve the soft tissue and to avoid the bone loss that we used to have around the implant. So we rethought a special setting where we were not thinking the same way as before. We didn't want to have a set of implant with enlargement core, because we wanted to increase the primary stability of the implant and also to increase the developed surface. And we will develop that. So we reduce the diameter of the implant core to 2 diameter core, 3.5 and 4.3. So 2 diameter for the core, but 3 large spire, like he explained you, Cedric, before. And all the innovation comes from the horizontal spire that are extremely large. They have a shape that is extremely aggressive in a sense that they were particularly sharp and able to penetrate the alveolar bone to stimulate it without traumatizing it. And at the same time, we wish that the core of the implant was reduced. That way, it could leave more space for the live, for the cells, for the bone, for the blood. And we will see in the 4H protocol all the logic that is more preserving than what we had before. We will see also that the clinical indication will be much broader than with basic ranges. The iBone concept is built on the bone and gum preservation. And like that, we can increase the indication, but we wanted the implant very simple, and we wanted the reproducibility of the process. And you know, as perhaps you don't know, but I am educated as implantologist, but also in prosthodontics. Therefore, when I perform my surgery, I always think at the future prosthetic rehab. And I try always to analyze what I want to correct regarding the techniques and the biology. So with my dear colleague, Dr. Hervé Tarragano, we decided to come back to the fundamental techniques and biological consideration. And I want to tell you that why this design feature influenced my surgery. If it's not an immediate, if it's an immediate implant, a full arch, a partial edentulous. But very important thing to tell you before the presentation, you don't need to forget, it's very important to don't forget that the implant is only a link of all the chain. We need to take care of the volume or the quality of the gum, the bone volume, and how you will use the implant, how you will put it supra or subcrestally, and everything is very important for that. So don't forget that it's only a link. The first fundamental technique consideration for me, when I want to decide which kind of implant I want to use, I need to see first of all, the prosthetic aspect, and specifically the internal connection. So now we have a connection that is with a conicity of 11 degrees. It means that a very good sealing. We have the platform switching. This is and this connection is very stable, mechanical stable, resistance. And it's a long time, 14 years, and it has been validated by different kind of tests. And also, when I decide to choose an implant, I see what kind of tools, of prosthetic tools I have in my box. It means what height, what diameter of the healing abutment of the prosthetic for the temporary, for the definitive, for the abutment multi-unit or something the same. For example, in ETECA, we have the tetra, the pilier tetra abutment, and also a very good healing abutment that we have is the iphysio. The iphysio is the abutment, the healing abutment that you can put directly during the surgery, that it can provide you a very nice gum design, and you don't need to remove it until the time after you put the crown. It means that you can take the impression directly on the, or digitally, you can take it directly on the iphysio, and you can take the impression directly with your elastomer if you need. And you can also put your temporary crown directly on it. And you can also manage the gum with the technique of SSA, described by Gary Finnell, our friend. And so when you know that you have a lot of tools to work like you need to work, and like you need to provide a very good prosthetic for your patient, so you can now see what there is under the crown, under the prosthetic, and now we can see when talk about the implant. The second consideration, important consideration, the first is not design implant, because we are usually measured the developed surface. We won't choose this implant for its width, or the height, and we will associate it with the total surface development. And I will show you. Usually when you put implant to restore a tooth, you decide to choose, for example, this one, the 3.5, for example, 10 millimeter. If you see the total surface developed is 125. And if you want to augment the bone stability or the bone implant contact, you need to change the implant and to put a wider one. For example, you put the 4 millimeter and you arrive on only 147 millimeter. And if you want to make a larger one, you know that you need to remove more bone. Okay, you have an implant that is 5 millimeter, have a diameter of 5 millimeter, but you arrive only on the total surface at 187. There is another way that you can augment your surface is to choose, for example, this kind of implant bone, iBone. And if you see the surface that is developed on the first diameter and the first diameter of the spire, 3.5 and 3, did you understand that the first number is the diameter of the core, the second number is the diameter of the spire, and the third number is the length, okay? And if you want to augment the surface of the stability, you don't need to change the diameter of the core. You don't need to remove more bone. The only thing that you need to do is to change the diameter of the spire. And immediately, if you see, you augment significatively the total surface. You arrive at 185. And if you want more, you don't change the diameter of the core, only the diameter of the spire, okay? And you arrive for this one at 232. Okay, we said it's too much, too many numbers. It's complicated to understand. But if we compare these two implants, for example, this one is 5 millimeter diameter. We have 187 millimeter square. And the iBone that is smaller and thinner than the other one, you arrive at smaller because the core only 3.5 and 4.8 for the spire, we arrive at 232. It means that with the second one, you have 30% total surface more than the wider one. So now you can imagine all the clinical situation where this implant is designed, this implant design will help you. And of course, all the usages that will be more varied than what you used to have before. Let's see these cases. If you see these cases, we would like to put 2 implants, okay? But we are limited because the bone is too short. And if we, non, j'ai besoin de la connexion. And sorry. And if we see the position of the lateral nerve, the mandibular nerve is giving you not enough high. And if the patient don't want to make a bone augmentation and want to reduce the surgery, is afraid of the bone graft or bone regeneration, we decide to put very short implant. And if you see this implant is only 6 millimeter length and 6.2 for the large part of the spire. And I'm sure you will say, and we finish, you said, we will finish this case and we'll show you the result. We put the implant, the crown directly, screw retainer. I don't like the cement crown. So it's better to have only screw retainer crown. And we take the X-ray, everything seems fine. And I'm sure that you said, what is the total surface for this implant that seems so short? And you see 188, but I'm sure you would like to have a comparison. And the comparison is this one. And if you see this implant, those implants with shorter but longer, thinner but longer, we have exactly the same. But it means that you think that you need to put a very large one and very large, but you don't need. If you change the design, it's why the design of the implant can help you to provide you some more result and less surgery. And you see on these cases, those two implants have a quasi same development surface than this implant of 10 millimeter. We couldn't have imagined that the short and the small implant will have a wide developed surface. What are able to obtain around the spire quality and the bone, quantity of the bone is, and of course, a very stable anchorage. Here we have a strong bone density, and because the spire are very sharp, it will be able to penetrate at the bone, okay? That is not so vascularized and raise the simulation of the bone. And once you have done the drilling superior at the core, you don't have the compression of the core, the horizontal spire will do the rest of the work because they will penetrate very gently in the bone. Let's see another case. For this patient, we put 4 implants, including the post-extractional and in a replacement of the first molar, and we still have a very few bone. And we put an implant of 6 millimeter diameter only, 6.2 of the width. And I'm sure you will be wondering that what is the future of this little implant right here? It looks so thin, so limit ridiculous. And although it seems thin, but the surface developed of this implant with 6 millimeter only, the diameter, arrived to exactly the same than the other one, and perhaps more than the other one. So visually, it's shocking enough because we see a thin implant, but the most important thing is the developed surface. In another clinical situation, this implant will be magical. In post-extractional, you just have to store the diameter of the core and then to follow with the width of the spire, which will look to store on the horizontal way to rise the developed surface of the storage in the implant, the forage of the implant. And it's really a big advantage to have this shape and profile in the layout of this implant. In the different and exactly the same situation of this implant, you see that this one of 5'10", you have exactly the same surface, total surface development. And just to show you that, to explain you that in the different trials, we have tried different kind of spire with the OTK Société and the Lyra. We have tested them, different kind of spire, and we wanted to see how the implant wouldn't stay stuck, because once you overdrive, you stuck the implant. With most other system, you stuck it. And we designed the performance of this implant is to have a very, very good activity in the apex of the implant, and like that you can enter in the bone without be stuck. And the protocol of forage was studied that we couldn't create an important friction point in the bony recipient. Okay, but what we wanted from the beginning is to really get a very good anchor and no need to compress the bone. It's because we have this horizontal spire, I'm repeating again, that can penetrate the bone in an efficient way and without traumatizing it. Cédric, would you like to explain us the third fundamental consideration that we call the healing chamber?
Yes, of course. So the protocol is done in order to make a hole a little bit larger than the core of the implant. And so the stability of the implant is not done by the core of the implant in contact with the bone, but it's done by the thread, by the spear that's going in the bone. So that means that we have some space between the core of the implant and the bone. And this space is very important because like this, we cannot have some blood going in contact with the titanium And this blood is full of calcium, of phosphor, and this ion will be linked to the titanium oxide on the surface of the implant. And this is the start of the osseointegration. And that's why it's very important to have this space. And everybody knows that when we have very cortical bone with no blood, the osseointegration will be long, difficult, sometimes impossible. So here we have the space for the blood and for the osseointegration. That is the beginning of the osseointegration. So here you have
the forage protocol.
It's a forage protocol.
How we can obtain this chamber? Explain us.
Yes, so this chamber, when you have in the kit some conical drill, so you have to use the good conical drill. So when you have an implant 8 mm length with 3.5, you take the green, the yellow one, and you choose the good length. So the hole is really done for the implant with small chamber. So when you have a thin thread, you are just to drill, and that's all. And when you use a large thread, and when you want to have, you have a cortical bone, and you need to have a big hole in order to have some more blood, to have bone constriction, osteointegration, you will use the straight drill that really adapt to the thread. So to the outside diameter and not the core diameter. Like this, you have a stability done by the top, by just the thin thread, and you have some space for the blood. So you can see here, by example, you make a hole, you have some blood. If you put a standard implant that we have all like a natural, by example, you have no space for the blood. And with our protocol, we have a bigger hole and we have some space for the blood and for osteointegration, for the future osteointegration. That helps a lot. So here is this explanation. So on the surface of the implant, we have titanium oxide, and this titanium oxide will be linked with phosphor, with calcium. And this is very, very important because the link between the ion of calcium and phosphor that we have in the blood will start to have the osteointegration directly in contact with the implant. And this is a key for the beak in the future and stability of the implant, the second stability of the implant. So all this is a study about, it's a University of Paris, La Sorbonne, that has done this study. Some students have worked on it. And they explain that we need to have some cicatrization of the blood. And this cicatrization, when it's inside the bone, is a key for the construction of the future bone, of the new bone around the implant. And this is the last one is when we explain the cicatrization. So when you have when you break the bone, you have some blood everywhere, and the body will start to stop this link of blood, and by stopping this, is making a construction of the new bone with the titanium oxide of the surface, with the fibrin and all these things.
Okay, very interesting. Cedric, let's see for this implant in an extracted site, when what is interesting in this case, that is that we didn't use a drill. This tooth, the premolar, was abandoned by the patient, and we wanted to replace it. But by seeing the alveolus ready to receive the implant, I put the implant directly. I didn't remove it. I didn't drill in. And with the tool of NSK OCO 100, we are able to test the value of the stability of the implant. And this implant, with this implant, has put with only the anchorage, the anchor of the horizontal spine. And we arrived on the ASQ of 72, which is huge. And if we zoom in, we can see at the drilling concept that the particularity of this implant is the concept of the healing chamber is to install this bony crypt, and for the new bone will be able to form. All the studies have shown that after an extraction, you don't even need to realize any bony feeling, or the osteoblast and the osteoclast will work by themselves on generating. So why continue with the drilling? We can put directly the implant like this situation. It's exactly what we are doing. Indeed, we are not seeking to occupy the space with a hyper aggressive manner in using a width that is superior of the width of the alveolus. We want to use all the biologic assets that we have, which are the bony cells and the bloody cells, and all these assets that are in favor of healing. All the basis of this implant is only on the preserve the nature, mother nature. And if we see this picture on the occlusal view, on this left view, when the implant has just placed in the area left all the space of the living at the same time in lingual, and at the same time the bladder. And here we can see very well the anchorage. Only on the anchor happened only with the horizontal spine. The neck and the body are not compressed. And if you see the difference on the two pictures, only 30 seconds. 30 seconds separate those two pictures, and you see that the crypt is very quickly filled by the blood and further by the bone. And we don't need to fill it, or perhaps with this biomaterial, we can fill only the entrance of the crypt, but we don't need to fill all the crypt of the alveolar of the tooth. And exactly the same situation with this bone. With this implant, we put it in a very good quality of the bone, but we don't want to put a very large one. We preserve the bone. We put it subcrestally, and we let it heal and during the orthodontic treatment. So you understand, so you understood all the concept of the protocol is to not aggressing the bone and let the bleeding for it to be the horizontal spine that will seek for the horizontal anchor. And what we saw in the previous picture, exactly what happened on an inferior level at the left, at the level of the room of healing, of the room of the chamber of healing. And the drilling does not happen on the width core. I repeat again, we don't drill at the width of the core, and we drill a little bit more than the core, and only the width of the spire will allow the biologic to happen. So the first fundamental consideration for us was to protect the bone, and specifically the cortical bone. So we wanted a design of the implant that not compression on the cortical bone, and we wanted the sharp and deep thread. And the cortical bone preservation is very important for us, as Joseph Choucroun, Dr. Joseph Choucroun learned us that we need to reduce what we call the oxidative stress. It means that when you augment the image and you see, and you try to focus on the contact on the collar of the implant and the bone and the cortical bone, you see that there is a little space. It means that with our protocol of forage, we let a very little space for the cortical bone to come and to heal on the implant, and not to compress the cortical bone. It's not the same objective on the cortical bone and the objective on the alveolus bone, on the cancellous bone. And we see on this other picture, we let a very small space, very thin, it's not very large, but it can provide a very good healing of the bone around the implant at this moment. And you see And another way to use this implant is very incredible, because now with the chamber of the healing and with the wide diameter of the spire, we can use it very simply and for the immediate implantation after extraction, because you will have very good stability, primary stability. Look at this situation. We remove these two teeth and we wanted to put immediately the implant, and we finish the case. Perhaps I have a smaller remark on the prosthetic aspect. The technician chose a very short neck of the abutment. I think it's too short for the biologic width, and it was better to ask to the technician to take exactly the same diameter than the healing abutment. But my correspondent, my friend, didn't know that from the beginning. So it's why we see on the left side, we see the pressure that we have on the gum. So we need to take care of this situation. I hope the situation will going well. And it's exactly the same with this other situation. We put the implant on the 36, on the 46. We remove the root, we put directly the implant, and we perform the crown immediately. And exactly the same of this post-extraction. On this post-extraction, we can put directly the implant, and we can use a tool that we will describe after, is a reamer, that it can help you to condense the bone and help you to augment the stability, the primary stability, without reducing too much bone. And you see that even with a short diameter, we can provide for this implant, I think I forgot pictures, this was with the temporary crown, So we made immediate loading because we get a very good primary stability, so we can put the temporary crown immediately. Okay, let's see these extreme cases for the replacement of this 36. We can observe the primary stability we get in the value of EISQ 64. Here, the sitting up an implant with his specific design will the bone to heal all around the implant. It means that the bone will embrace the shape of the implant, and there is nothing better than this type of healing rather than an implant that compresses the bone. Another very important consideration, fundamental consideration for us, is to have a surgical tool to reduce the bone loss. And we will explain what kind of tools we have in the box, in the surgery box, and specifically it in the other side. This means on the anti-clockwise or the non-circular way. When you use it in the other way, you have a condensation. And this condensation will give you the same effect that we have with the DENSA, the DENSA protocol. But now you don't need to buy another tools. You have everything in your own box, and you don't need to invest in another box. And if we see, you see that the surgery box is very, very simple. You have one line with the first drill, the pilot drill, and you have after the reamer. The reamer, you can use it on one side or on the other side. It depends on the effect that you want to obtain. And if you change the diameter of the implant, you have the second reamer to continue the action of the first one, or to remove or to condense. It's very, very simple. And you see, when you use it on the circular way, you can take you see the blades are very deep and all the bone keep inside. So when you drill, you keep all this bone. It's very important. And you can use it on the other way, on the non-circular way or the anti-clockwise. You put reverse on your motor, okay? And you can condense For example, in this situation, we will explain, we will show it after the total clinical case. You put directly on the septum and you can dance without removing. And like you can change the shape, you can see how, I don't know if you see how you change the shape of the root just because we condense the bone. We don't want to destroy it, we want to preserve it. Obviously, we can start to imagine more extreme situation. What does mean extreme situation? It means that in this case that we have a very short level of the implant, we would like to put the implant, but we don't want to put a very short one. For example, if you don't want to put a very short one, you decide to perhaps to push pilot when you use side on the anti-clockwise and you push apically, and the reamer, this reamer have the apex is not working. It means it's not sharp. So you can only push the bone upper, and you can with the pushing, and after when you put the implant, you can keep all the bone that it was in the inside, and you can push it under the sinus. Let's see this other case. This case is very interesting because in this situation, usually the patients came for the sinus lift, for the sinus elevation, okay? But when we take the CT scan, we see here the arteria, the antral arteria, and we see that the bone is very, very thick. So we don't want to open very high, and here it's too short to make the window. So we decide to try to push the limit of the implant and to see what we can do with it. And we decide to do exactly like this, the previous case. It means that the first drill until the cortical, and after the reamer, but you put it, you turn it on the reverse side, and now you see that you have pushed the bone and the cortical, and you push it under the sinus, under the membrane. We take X-ray to be sure, and after we aid this, because it will not be enough, because we wanted to put a long implant, we decided to aid bios and to push during the same procedure and to push the bone under the sinus. And after, we can put directly the implant because you have prepared everything. You have a new bone that you did both together. The sinus elevation, like described with Summers, it's like a technique Summers, but with your own tool and directly. You don't need to put the hammer and to push with your hand and to be it's more control. You have more control with this kind of situation. And if we took the CT scan for after the surgery, we see that we didn't destroy the cortical under the sinus, and the bone graft is very perfect. And we can repeat many times this kind of same surgery in this situation. Let's see this one that we can combine the post-extraction and sinus elevation, okay? For evident reason, we decide to remove these tools and to put an implant immediately. The patient is flying, but not for the moment. She's not flying enough because she's a pilot. She don't have work. She said, okay, but now I have time, but I don't want to wait a long time to remove and to put the implant the second time. So we decided to do everything in the same day. I would like to excuse me for the quality of this kind of these pictures. We take it only with the iPhone, and it's not a very nice picture. You will see the other pictures after. But here we remove the crown. We see the broken root in this area. And what we did with the first pilot, we drill in the middle of the septum, okay, directly before to remove the tooth. Like that, it can help you to find exactly the middle of the bone. And after drilling in the middle in the septum, you remove the rest of the roots. Okay, and after you use the reamer on the reverse side at 500 to a minute, and pushing like that, and like you can have a very nice condensation like you see, and it helps you. As I told you, we can feel the cavity, the occlusal cavity is mean only with the biomaterial. I prefer the bio-wasp. I don't want to make another surgery to take the bone of the patient. And we close now gently, and we see the result of the situation before and after, and we feel confidence with this kind of situation for the future. I wanted to see if we can do exactly the same procedure on the lower jaw. We know that the maxillary jaw is very soft, so we can do easily that. But in the lower jaw, it's not easy. So we decide to try, but I don't want to compress the cortical bone. You remember, I told you we need to take care of the cortical bone. So what we see on the CT scan on the left side, we see that we have cortical on the two sides, and inside the cancellous bone is not very dense. So we said perhaps we can try to do some kind of distraction, and we drill with the two pilot foray, okay, pilot drill, and with exactly the same procedure than in the maxillary, you turn on the reverse side on the counter anti-clockwise, and you see the condensation that you have on the cortical bone, even on the cortical bone. But even in the scene, you see in the middle, the picture of the middle, you see the difference between the one that we, without removing bone. You understand that? Because we are on the anti-clockwise, we don't removing nothing. We only push the implant on the side. And you see the difference, and we did exactly the same for the other one. But I know, you will tell me, you don't have enough bone. Okay, but don't worry. But we can put the implant at this time, okay? And we can continue the procedure with the bone regeneration, with the membrane, fix it everything, and the suture, and we can see on the CT scan, the immediate post-op CT scan to control the bone regeneration that we have. But the patient went with the implant immediate, that we can put it immediate with this kind of procedure. And we can do exactly the same for this patient. We see that you see the bone is a little bit thin, and we would like to put the implant and to try to do exactly the same procedure than before. So we show you the X-ray after the surgery, and I show you what we did, exactly the same than before. We use the pilot foray, and after we go back with the reamer, like that, we condense all what we can condense of the bone, okay? But we need to be very careful. We don't need to compress the cortical, okay? So do it very gently, but you need to do it with irrigation, of course, to don't hit the bone. And we can put the implant, okay, directly. And if you see the photo on the picture on the left, you see the bone, how the blood is going on directly on the implant when you put it in the site. And if you see what I told you before, that we don't have compression on the cortical bone on the collar of the implant. And we can continue the procedure, and after we can finish the case, because we take the impression, and we have a very nice gum now, and very nice gum, and you see the crest is enough rebuilt with our procedure, and we can put the crown directly, okay? Always screw retainer for the crown. I told you many times that I will repeat it enough. We try to use only zirconia crown, because the quality of the healing of the gum around the crown is better with zirconia, and only screw retainer, because we don't want to have cement in the sulcus and to disturb our surgery and our bone, of course. And we can see the healing immediate. The crown have been done, and we don't forget to choose the height of the of the sulcus of the prosthetic need to be like that, minimum 1.5 millimeters, and it's better if you put 2 millimeters. Okay, and you see that the bone is going on the collar of the implant because it was an implant iBone S, and with the microstructure that we had on the collar, we can protect the stability of the bone and the gum. And we can continue with the same procedure and doing exactly like I told you on the reverse mode, on the anti-clockwise, we can push the implant directly under the sinus and is more comfortable for us. But sometimes the bone is very dense. So don't do that when you have a very dense bone. So don't force the biology. It means that with this one, for this time, for this implant, for example, this situation, we will do it on the clockwise. It means like it usually we need to remove, but all the bone that we remove, you put it on the side, you see on the picture, okay? And now we can use it, mix it with BioOS, for example, or xenograft. We can use it, mix it with it, and we can make our bone regeneration to augment. And we did that a second time for another patient, exactly the same with a membrane and using the bone of the patient, mix it with the xenograft, okay? And when on the maxillary, we can do exactly the same, but in the other side. So you need to judge at what time, what kind of surgery, what kind of bone you have. If you have a bone with a less density, you can do it on the reverse side to condense the bone. And when you are the cortical, don't do that. Just remove bone and put your implant very gently to not compressure. Don't forget that. And I want to show you some situation that I'm sure that you will told me that we cannot put the implant on this situation because all the article ask you from Del Fabro and many others article told you that show you that we need to have minimum 4 or 5 millimeter to put the implant at the same time of the surgery. But we don't have exactly the same design implant. And now with this kind of spire, very aggressive and very stable, we can perhaps, and we will see on the surgery, if we can put the implant immediately. And I will show you. So we did the window, the lateral window like we used to do. We raise the signs. We fill with the bone like we used to do. And now we put the implant. And we see that we choose an implant with a 5.8 of diameter of the spire, and with the very good stability that it can provide you only on 2 millimeter, we have a very good stability of the implant, even if it's in 2 millimeter. And we finish the surgery with the bone graft, with the lateral windows that I used to put again on the same position, and of course a membrane to protect everything. And now, I don't remember. Okay, I make a mistake of the range of the pictures. This one was supposed to be before. And to show you that we use exactly the same reamer that I told you before, it means that even on the 2 millimeter that we have, it's very, very short. But you can use the reamer to continue to augment the density of the bone. And you put it on the reverse, and like that, you can augment the stability of the bone. Okay? But we can see some other cases we don't need to have a very large spire because it's implant with the shape and the shape of the core, the conicity, the conical core, and with the design of the spire, even if they are very short, but they are extremely sharp, even if they are short. And to show you for this simple case, but we extract these two tooths and we put in 2 implants, and we decide to add the gum to have a nicer gum. So we used mucograft from BioOS to try to rise, to augment the tissue, to augment and to have a very nice, more keratinized and almost a volume to protect those implants for the segment. And the patient went back to this dentist and continued the situation. Even if in this case, we usually don't use to put for first molar, the second molar, we don't use to put short or very thin implant. We used to, psychologically, we are more comfortable when we put very wide one. And if you see, we finish this case with a very good stability of the implant, of course, but we have a total surface development, very important. So in this situation, you see that we don't need to put a very, very large implant, okay? And it's the interest of this system. Exactly the same situation for these 3 implants. Okay, we have a good bone, normal bone, with a density that can help you to put this kind of implant. It's mean with the medium width of the spire, and we can finish all the case. Don't forget to choose the height of the collar of the abutment, the tetra abutment. They can 1.5 minutes or minimum 2 millimeters to keep healthy your biologic width. And the picture is like that, to see that you have a very nice healing of the gum. Always think of the gum, and we don't have only a good healing of the gum, we have a good high of the gum. It's very important, and Linkevicius show it many times that we need to have minimum 2 or 3 millimeters of the height of the gum. And this is an important point to prevent the periodontitis or implantitis, excuse me, and to prevent gum defect and also bone defect, by the way. And we can take the impression, or like we used to do with the indirect abutment, and do the direct procedure. It means with always, like I told you, with a screw retainer. And we can have a discussion on if it's better to put only 1 implant on each implant, on 1 crown on each implant, or to if we can accept to have solidarity crown. It's a point of view. It's a point of view. For me, it's easier and more comfortable for the patient. We can close the space between the teeth. The patient you don't have food stocking, and it's more comfortable for me. But I read many articles that say sometimes it's better to put 1 implant and one crown, and sometimes it's okay to solidarity. There is no consensus for this aspect. But you have another option, is to take directly the impression on the iphysio abutment. What is wonderful is you don't need to remove, like I did here before. You don't need to remove the healing abutment. You put directly the iphysio. You have different shape depending according to the tooth that you need to restore, and you put directly, and you can take the impression directly, like he did my friend Jack Chelius, that is going to organize the next webinar, and he will show you how this kind of abutment will help you to have, first of all, very good quality of the tissue. You can reshape exactly the design of the future crown, and it's not the crown to force the gum to have the form that you want to have. Is the iphysio. It will give you exactly the shape, and you don't need to remove it to take the impression, or digitally, or even physically. If with elastomer, you can take it directly the impression without removing it. Okay, and also if you see there is a screw in the middle that you can put the temporary crown directly on it, and many options that is very wonderful. We will explain you that with more detail abutment, and you will receive directly the crown. So it means that when you remove the iphysio, you put directly your restoration. I have to tell to my friend Jack Chelius that I'm afraid all the time with the cemented crown. So I'm sure that he cleaned very well, but I'm always worried when I see this kind of restoration. I see we have a very nice gum, and it's a pity to have cemented going inside the healing. Okay, the abutment. Okay, so it was a small joke between us because I love it. Okay, and let's see another case that's exactly the same that we did before. If we can put the implant with a very low high of the bone, and we see exactly the same procedure. We put we made the extraction of the canine. We did the same lateral window. We raised the sinus. We put the bone. We put the implant, and we see it before to finish the penetration in the bone. And we decide with the same procedure to put the implant on the 16, on the first molar. And even we had a very small, short level, and we continued the procedure with the bone graft on the canine and the membrane and everything. We finished the surgery. Okay, so this kind of implant and this kind of design help you to reduce the number of the surgery. For this patient, if I did only the surgery, the sinus lift and only 3 implants, and I told to the patient I need to come back in 5 months, okay, it's better to do it in the same time. The patient is happy. Okay, let's see another case that the patient is referred to put for 4 implants in this area, and we take the X-ray. We don't have enough bone, so we decide to put implant. The thinner that we have is only 3.5, and we see that we did exactly the same procedure that before, the foray pilot, and after the reamer on the removing, not the condensation, okay? We remove the bone, we keep the bone on the side, okay? We put the implant a little bit above the bone, it means deep, a little bit deeper, okay? And we see the protection of the preservation of the cortical bone around the implant, around the collar, and all the bone that you had, that you find on the reamer, you mix it with your biomaterial, for example, or the bone of the patient if you want to open another side to preleve some other bone. But after we can do exactly the same surgery, and we finish the surgery like that, and you have simple implant like you used to have with a very good stability. And for the second stage, we see that we have a nice bone covering the implant, and we put the healing abutment, and we see the really nice result of the gum, not yet, but very nice result of the gum, and specifically around the collar of the implant, and the patient can go back to see his dentist to finish the restorative part. Okay, let's see this case that is very strange because the patient had many implants, but not on a good position, not on the good design, and she broke these tooth. The first central incisor. So she was very worried. And when we see the X-ray, we don't have enough space to go in and to find more stability here. So we decided to remove this implant, and we try to use some tools to preserve all the bone and all the gum around the implant or the future implant. So we remove the root, and we use the pilot drill to go and to check, because we wanted to be sure that we are on the good direction. We didn't have time to do surgical guide. So we prefer to make some X-ray to be sure. And like you see that when you put the implant, you see how the blood is going very quickly on the implant. It's very magic to actually see this kind of nature going on around the implant, and they accept the implant when the implant go in. And you see, when you present the implant, you have immediately blood that's going and try to cover the implant. Okay. And of course, we put the implant on the palatal side. We find a very good stability, even if the bone was very poor. because we have the very nice spire, like we told before, and we feel with by xenograph product, and we decide to put in provisional immediately. And you have the X-ray immediately after the surgery. The gum is a little bit high, and we see that with kind of surgery, even the implant is a little bit deep. You need to be deep, for my opinion, on this case, on extracted immediate loading, we need to put the implant minimum 4 millimeter above the gum, the level of the gum, okay? And now we see only 2 weeks between these two pictures, and we see that there is a gum is going on the temporary, so we are happy. In this case, we decided to remove these 4 tooths for evident reason, broken, but the problem is that we don't have enough space to put the implant. So when we remove the roots, we cannot put the fourth because the roots was too narrow, too close. The roots was too close, one but the other one. So we decided to put only 2 implants in the middle on the central incisor and on the palatal side all the time to keep bone on the, voilà, yes, you see, to aid bone here on the buccal side. And like that we can preserve. So we make bone augmentation on bone graft on the sockets of the socket of the other tooth, and like that. And we feel all what we can, okay, like you see. And after we put the temporary healing abutment immediately, because we don't want the gum to collapse and to lose all the gum that the patient have. And after with the temporary crown, temporary bridge, with the temporary bridge, we would like to keep the sculpture of the architecture of the papilla that we want. So we need to see the patient 2-3 times to change the shape of the pontic, and to help the pontic need to be a little bit on pressure on the alveolar of the gum to keep the healing. And now we didn't finish the case because we have a lot of force on the other side. Only with the healing, come tomorrow to take the impression, but he canceled. I don't know why, he was very busy with his work. And I was supposed to take the impression for all the case. And I will show, we show you the next time, perhaps, the finishing of this situation. Okay, but now we have, okay, I'm sorry. I don't know what I did. Okay. And let's finish the webinar with another case of the 2 front broken teeth that it was very pity for this patient. She was nice. She's only 30 years old and she broke these 2. But when we see the X-ray that she get before, we see that we can critique the crown, the prosthetic, the endodontics. But now the problem is that she broke this one and the other one is moving. So we decide to remove the 2 teeth and to replace it, to restore it by the implant. So when we see the CT scan, we see the CT scan that we don't have a lot of bone on the buccal side. So the bone is very precious. So it means I don't want to put a very large implant. I want to make the immediate loading, and I don't want to make a very long. I don't have a lot of space. So it's not so easy. So we prefer to perform with an implant that provide you good stability. It means that you can have with the large spire, find the good stability. We see when we remove the tooth, we see that when you present the implant immediate on the tooth, you see the blood is going directly on the implant. The blood likes this surface, and we put the 2 front implant like you see, and obviously we put it a little bit palatal side on this palatal side, like we know, because we need to, and on the direction that we have the screw going on the palate, on the level of the cingulum, okay? And for the occlusal view, we see that we need to feel with bone, and perhaps for this patient, because the gum is very sensitive, because the biotap of this patient is very, very, very low. So we decide to put implant, to make the bone graft on the bone graft, but bone graft, and to make a gum graft. Okay, so before to make the gum graft, I need to restore the patient. So we choose, like I told you before, the pilier tetra. It means that we put it immediately during the surgery and we will not remove it after. Okay, we will fix it immediately. And the only thing that we are going to put temporary abutment that is going directly on the tetra abutment. We try the temporary crown, but we see that the gum is very thin. So we decide to aid a gum graft and to augment the situation, the poor situation of the patient, and to provide us some security for the future. Okay, so and you see on the, okay, obviously we don't do incision, discharge, incision, lateral incision. We start to do only with tunnelization. We don't cut even the papilla. We didn't cut it, so we need to buy with different kind of suture. We go deeply and without touching the papilla. It's very important. Okay, and with this occlusal view, you see that we augment the gum tissue. We have the bone underneath, and we have the two implants with a very nice abutment. And after we can fix with the screw abutment, on the screw temporary abutment, we can put the temporary crown. Okay. So when we take the CT scan after the surgery, we can see that we put the implant nicely on the palatal side. We aid the new bone on the buccal side, so we can and the implant is enough deep to have emergence profile. That is very important to have a very nice result for the future. With the new smile of the patient, I will show you the result. And in conclusion, what I would like to tell you is that we have now a very nice tool. I would like, first of all, thanks a lot, TK team, Cédric Lancieux, Bénédicte, and of course, my dear colleague, where I was working a lot, Dr. Hervé Taragano, that I would like to thank him because we are a very good partnership together. And of course, the CEO of the company, Michael Wana, and of course, Armand Stemmer. And of course, the 500 participants from all over the world. I'm so proud. I hope that in a few minutes we'll send us, like in the Eurovision, we will ask Italia how many pounds they give for me and for Ukraine, because I have a friend in Ukraine, how many pounds they send to me. So okay. So now we have for ourselves a range of implants with different width, different length. And as you have the opportunity to use it in complicated case, but also in all the simple case. And I'm sure that it will seduce most surgeons' profile, but the problem is when you start to use it once, you became addicted. So if you want to try to use this implant, take care, because I'm sure you will be addicted, because you will understand all the philosophy of the concept, and you will be very happy to use it because it's simple, and biologically you have all the tools to give you and to provide you very good result for the future.
Thank you so much, Dr. Pinto, for this great webinar. We really love all the different cases you have been presenting tonight. And also it's a lot of, different explanation on different situations. We understood it gives a lot of new options for actually with this new implant. Before we start actually answering all the different questions, just a few points. So today on this webinar, we didn't really detail what is the surgical and drilling protocol. So you're going to receive it in the next few days, the exact drilling protocol, but you will also have a recording and also additional pictures of the different cases that Dr. Pinto has been presenting tonight. Regarding the availability of these implants, it varies based on your location, meaning that if you're in France, these implants, I mean, these three implants, iBone E, iBone S, but iBone G, are already available. If you're located in other countries, it depends. Actually, you need to contact your local reseller and it will give you more explanation about how to test and how to get this implant. Now, like to answer all the different questions that we have here, I will try actually my best to communicate them to Dr. Pinto. If we're not able actually to answer them tonight, feel free actually to type them and we'll make sure to give you a detailed written answer on your different questions. If I start actually from the beginning, one of the first questions from actually Kevin Pear was about like why this idea of large or specific threads was not applied on Natural Plus or Natural Actis. I'm pretty sure actually you've seen that the implant body is different. So first, you know, like this is not applicable on Natural Actis and Natural Plus because we're speaking about all different concepts. So this is why like we didn't want to confuse or add or anything, you know, to the existing implants. It was making more sense for us, you know, like to create a new implant range. Also, as you probably seen, you know, Mr. Cédric Lancieux and Dr. Pinto have shown you that this implant, you know, by the way, made in France and developed in-house, has been, you know, in the box for many years. So it was not just like an adaptation of the Natural Actis and Natural Plus. It's a brand new concept. So this is why actually I've not been able to do this.
Exactly. It's a new concept.
Yes, it's clearly, we can say that we have the brain mark. Brain mark is the first generation of implant. After that, we arrive step by step with conical implant, like a replace, like a natural. And after that, we have a Natural Active, Nobel Active, SPI. That is second generation of implant. And here, clearly, it's a third generation of implant. It's a new concept. It's not just a small improvement.
There was a question regarding the drilling protocol. Again, as I was saying, we're going to send you it by email. So you're going to have time to review and really understand it step by step. It's going to be easier than actually coming back to the different slide. You have been asking if we can get additional cases on thinner ridge. I guess after the question, Dr. Pinto, I've shown you different things. So I hope actually we answer this question. And it was also another question regarding the crown implant ratio. Maybe Dr.
Yes.
Pinto, I will actually let you answer this one.
Yes, it's true. It's a good question because if you read some article about the mechanical aspect was talking only about the length, the ratio between the length of the implant and the ratio of the prosthetic part. It means that they never talk about the total surface development. And if you understand that there is one implant that one of the oldest implant, it's called Bicon. Bicon is an implant that was very difficult to use because it was impacted, and they had a very large, like it's not a spire, but it was like different floors. So you can impact this implant. It was very short, and they have more than 40 years background to understand that very stable, the ratio between the implant, even if it's short, but it's depending of the total surface development, okay? So I think you can be comfortable when you have a very large surface contact between the bone and the implant.
Thank you, doctor. I don't see any other question. Feel free to ask, actually.
There is, I read a question. It's written, do sharp spire will enable to stimulate the bleeding of the bone like we could do with another instrument? Yes, in the question, there is the answer. We want to use the blade that is not aggressive. And I need to admit that when we speak about logistic, it was about being easy to obtain this result. Everything was made so the blade would be able to penetrate the bone with no trauma and activate this biology.
Okay, maybe you can, Dr. Pinto, you can remind us like how to choose the spiral width, compared with the implant body, with the core of the implants. How do you choose, for example, large threads or narrow or average? Maybe you can give us more explanation.
Of course, it's dependent, of course, of the density of the bone. If you have a very cortical bone, very, very, very cortical, you need to put the spire not very large. You need to stay in the medium width of the spire. If we go to further to the maxillary, you can use all the diameter that you want. The problem is always on the lower jaw, that the maxillary is very, very dense. But on the CT scan, you need to analyze what kind of density you have in the cancellous bone, and it gives you the result. And after, you need to manage between the length, the width, and the objective of the stability that you want to have. And with that, you need to deal. I cannot answer, but normally, all the time that I want to have a good stability, I try to put the wider spire.
Okay. And Dr. Pinto, would you recommend actually this implant for beginners, or do you want actually just starting implantology, or do you think it's only an implant for the one that has been practicing implantology for a long time?
Yes, it's a good question, because when we developed this implant with the company, we wanted a very simple protocol. So with this simple protocol, this implant can be used very easily because you don't have a lot of drill, you don't have a lot of tools, you don't have a lot of process. It's very simple. You have one drill, and after the reamer on one side or on the other side, it depends of and after you put directly your implant, the primary stability is so incredible that when you start to screw it, it's going very deeply and easily. Okay, so it's very, very, very simple to use. So we recommend it for the non-experienced practice. Yes. There is another question. If we can have, yes, I think we have time. This implant has a very wide core. Do you more often perform graft with conjunctive tissue? Yes, the real issue with the real issue with most implant is how deep the implant can go. So you need to have an angulation of less than 30 degrees, and the conicity of the col and the cicatrization, the healing. It's why it's not good to put healing abutment too short. Otherwise, you will compress everything on the biologic width or the biologic width. So we need all the time, all the studies show you that you need to have a maximum of the gum. Maximum of the gum is minimum 3 millimeter. Like I told before with the different studies of Thomas Linkevicius, always telling that we need 3 millimeter. So, and for the anterior situation, all the time I used to perform to do surgery, gum graft surgery, all the time that I can do in the front side, because I prefer to have more gum than not enough.
And Dr. Pinto,
yes.
In general, what are the main indications for you, or have you had the chance already to place an iBone G?
The main indication is an implant that you can use in all the situations, because you can use it in the simple case and you can use it in the post-extractional situation is easier. It's easier to use. This implant is so simple to use. There is some other question, but this one is the same one. Show the case of anterior teeth. Show some cases for anterior teeth with thin ridge. But I show it in the end of the presentation. Okay. Do you choose the spiral width to the core width? Yes, it's a good question. Normally, all the time that I can use only the 3.5, I'm very happy. For me, the 4.3, we don't need to use it, but we do need to use it only if we need to fill a very big space, okay? Otherwise, with a very, obviously is enough for all the situation. You have some other question? How effective is this implant cause infection allergy? There is one question for Albania. How effective are this implant for not causing infection, allergy, and anything like that? Okay, it's why in the beginning of the presentation, I wanted to remind to everybody that the implant is only a link of all the chain, okay? All the process. You need to have this only a tool. If you don't know how to use it, you can have infection in any other implants. This implant is not a magic one. This implant gives you more confidence for different extreme situations. This implant will help you to put implant very quickly, easily, but it's not magic. You can have some problem with if you don't take time to drill like you need to drill, if you don't take enough the quality of the bone and the width of the bone. Don't forget that you need to keep 2 millimeter large with the bone of the buccal side is very important. You need to have the gum. All the process is only one part of all the chain. Is one tool. The other tools are the gum surgery and the bone graft that you need to do. But otherwise, it's only a tool, but a very nice and a very intuitive tool that you can use for all the surgery. But no problem with it's not the problem of the infection is. I would like to say that the most important for the infection is to control the quality of the prosthetic restoration. Usually, if you don't use a cement restoration, if you use very good quality of connection, like this implant, like with this implant, the conical connection, and if you have very good material like the zirconia on the crown, you have all the reason to have a very good bone crystal stability and gum stability with the time. Okay, so you need to deal with all. You need to deal with all the aspect of the surgery.
As long as you're using the original parts made by ETK, you represent yourself also, to this kind of problem. So this is really important. This is a point I would like to insist on. I have next to me Mr. Frédéric Lancieux, who have been reviewing different things, and this is really important that you're using the original parts that ETK is manufacturing in France for the prosthetics. I'm going to answer one from Mr. Kevin Pear. So yes, for sure, the prosthetic parts of Natural Plus and Naturactis are compatible with these iBone implants. Natural was another and previous system, and the connection is different. So Natural Plus, Naturactis, iBone for iBone E and iBone S. For the iBone G, which is the tissue level, is only working with the connection RP, meaning regular platform, and wide platform that you find similar with the Aesthetica implant and some Straumann.
There is a really good question about the, yes, you will also develop the full guide surgical kit. Exactly, Cedric is a little bit late on the development of that, but we have started that from the beginning of the process, but it's not easy. It takes time, but it's on the way.
Yeah, so the surgical kit for full guided is now is CE marking. So we received the answer today from medical authorities. So we have it for naturitis, and we will start the development for iBone.
So that's a good news that they are going to present really soon. We received the good news today. This full guided surgical kit is actually available and CE marked today. So thank you, Cedric, for this great news. I will actually share that with you very soon and giving you more actually explanation on how to use the complete guided surgical kit, giving you more information about, you know, like the full protocol and so on. It's coming up and we have the good news today. So it's really fresh.
There is another interesting question. Can this implant similar to Megagen, Straumann, or the new one with deep thread? Okay, it's very good question, because usually when you see the implant, you think that it's like the Megagen, but it's not the Megagen. It's something totally else, because all the shape of this implant is not the same. We don't have the same apex. This apex is very short and not aggressive, and we have it is auto-taraudant. This means that you can continue to drill with the implant. The other way, the space between the two spires is not the same on all the implants. On the Megagen is exactly the same. It means that when you drill on the bone, you need to destroy everything. There is a big problem with the technique of the implant of Megagen. For the Straumann, I tell you that I don't know Straumann enough, but only when I see the catalog, I can tell you that the problem is the diameter, because it's not the same philosophy. The philosophy of the implant is to keep the core thinner that you can, and work only with the horizontal aspect with the spire. And the Straumann, the body is going very, very large. It's not the same philosophy. It's totally different.
Yes, exactly. Yes, the iBone is self-taping. So compared to Megagen, it's completely different. And the same, the protocol and is different. So here we have really a protocol to with drill adapt to the size of the thread and not of the body. Now there is a main difference, and we have some doctors that was using Megagen as they changed to iBone today, and they are very, very happy. It's a big difference.
Big difference. There is another very important question about: is there a stop kit available for iBone implant? And I want to answer for Abu Dhabi, I think. Emira Rabini, yes, Abu Dhabi. And the answer is you don't need to buy another kit for that, for the stop, because all the drill that we have exactly the same level. So you don't need to buy something else. Everything is in the surgery box. Okay? So it's simple. It's what we told you from the beginning. And there is another question about, can it replace Densa? I tell you the truth. I have the Densa, and I don't use it anymore since I start to put this implant. So only with the reamer that is adapted to the implant, I don't need to use the Densa anymore. And the library.
Maybe a question.
Yes.
Sorry, Dr. Pinto. Maybe a question for Mr. Lanceux regarding, the digital library available for this complete guided surgery kit. Are they going to be available on the different, like software on the market?
So today we have FreeShape. So we are working with FreeShape. So as they start to make an integration of the STL5 in the Implant Studio software. So it's the first step. And after that, step by step, we will put this implant in the other software. So we need to work with a different manufacturer of 3D software for guided surgery or
yeah, of course. I know it's in process, I would give you details, but it's really close actually to be done.
Yeah.
Any other question, maybe more specific to iBone? there is a question here, like, is bone grafting required in all immediate implant placement?
For my opinion, yes, but only on the occlusal side. You don't need to feel all the length of the implant, only of the buccal side, because the healing is going to make the job for you.
All right, I think you know, like, I will go over the last different question, but I think it's going to be the time to wrap it up. Again, you know, like, quick announcement regarding a next webinar, which is going to be a complete different thing. This time, I mean, next month, on March 25th, you're going to be able to attend a live case, a live surgery, and a live scan on iphysio. So you will see live what the doctor is going to do. Is it going to be Dr. Shellus who's going to present this case? So if you're interested, again, this link is going to be there. You'll see that this system iphysio, like Dr. Pinto actually has been speaking during this webinar, it's a great and easy step to move on to digital implantology. So feel free to register already. It's going to be a nice, great event like we had this evening. So yeah, please feel free to register. Thank you so much, Dr. Pinto. It was really, really interesting to see all your different great clinical cases, a lot of x-rays, a lot of nicely taken pictures. So it gives a real picture of what we can do with this implant system. And it actually shows what is the trend and the new philosophy that you actually have been sharing with us around implantology. Mr. Lancieux, thank you again for attending this webinar tonight. And we will be in touch for the future. Thank you so much. And Dr. Pinto, okay. I give you the last word.
Just before to thank you a lot, I would like to tell you that Benedict is involved in the marketing aspect, and she prepared a box with I think 2 or 4 implants if you want to try, because when you try, you understand how to use it very quickly. So it gives you more opportunity to understand the philosophy physically. So you can try to buy the box directly, and you have something very new. So it's very interesting to, you will receive email. I think she's preparing that.
All right. Thank you. Thank you very much, everyone. And we wish you a good evening.
Excuse me.
Last one.
No, last one, because there is so many questions. So I try to put it on the same. Okay, there is one question very important from, yes, sure. I think Poland. This question is say that, so under bone level implantation, no burr to smooth bone level, and will emerging platform of implant. If I understand, the problem is exactly with the shape of the last reamer that you need to use, you prepare exactly the shape of the cortical bone. So we on the same instrument, you don't need to change something else and to put another drill. So it will be very, very helpful for you if you ask this question. It means that you don't need to use another tool to remove bone, to put your implant at the level that you want. First, the second question and the last one is about the bone, the D4 bone. The D4 bone means that you have a bone very poor of density, and it's exactly the perfect option for this implant. So for this bone, if you have a bone D4, the only thing is to start with the first pilot and the first drill, and after with the reamer on reverse, the first one, the second one, and you put what you want. Is very easy. You have dense the bone. It's perfect. So thank you very much, everybody. So I would like to thank you and to ask you to stay safe, and hope you will. I will find you. I will meet you physically in another congress, perhaps. I will be happy to talk about this.
Yes, no worry. We are going to organize it in different parts of the world. So
perfect.
For sure, we have the chance actually to answer. Thank you very much.
Thank you very much.